The topic of today is go-to-market in the Israeli commercial market. And we're very, very lucky to have Shira here, who works for Medtronic and leads commercialization, reimbursement, and other processes for Medtronic into the Israeli healthcare system for many years. So with no further ado, Shira.
Hi, good morning, everybody. Glad to be here. I'll just share my presentation and we'll start. Just a second. Okay, so hi, everybody. Great to be here. Looking forward for this presentation. Actually, you know, when you have a lot of knowledge, sometimes it's not that easy to incorporate it. So I'll just start by saying that I have a tendency to speak very fast. And there's a lot of information. So I'm just saying out loud, if there's any, you wanted me to speak slower or to have like more explanation, please stop me and I'll do. So a little bit about myself. So I've been working for Medtronic for the past 9 years. In my current role, I'm leading the strategic customer partnerships, focusing on the HMOs, and I'm also in charge of the government affairs for Medtronic Israel, together with Gilad and some others. Together with Gilad and others, I co-founded the Israeli Medtech Association, and I also act as the association secretary. I specialize in health technology assessments for national reimbursement. I worked for the Ministry of Health for 5 years for the National Health Basket. For some reason, it's moving. So I'm going to go back. And I come from a biological background with, you know, biochemistry and food technology background, biomedical science and health system management. And I live in Tel Aviv, and I'm a mother of twin 4-year-old girls. So just a few words about Medtronic, so you understand our market. So it's the leading company in the world for medical devices with over 95,000 people employed, with vast expertise and investments in innovation. And this was and is part of my position along the years within Medtronic, mainly in 4 pillars: cardiovascular, medical, surgical, neuroscience, and diabetes, which are diverse in their strategies. And I think one of the main things that shaped my way of looking at the Israeli market coming from the Ministry of Health is the fact that Medtronic in Israel is not just a commercial site. We're located here. It also has more than 10 locations around Israel for R&D, and more than 1,200 employees. And we interact with each other. It has a lot of, there's a lot of interchange in regards to R&D and research. And that's also one of the things that shape my vision and generally the way I see the medtech industry and the needs for startups in Israel, including the way that, to connect the dots, to make sure that this industry is strong and has everything it needs to thrive. Now, we're going to talk about generally like why I see Israel as a good market. We're going to have an overview of the Israeli healthcare system, and I'm going to talk about major consideration of the go-to-market strategy in Israel. Please stop me for any questions. If not, we're going to go that in the end. So generally, when I speak about medical technologies, I usually in my mind, they have 2 different medical technologies. First, medical devices, and the second thing is digital technologies. I'm going to focus today on medical devices. Digital technologies, apps, and everything like that is a total different ballgame. So I'm going to talk about the traditional, let's say, market. And when I was thinking about, for me, what is, the Israeli healthcare market looks like, I only had that picture of movie. I don't know if you saw it, won a lot of Oscars, but I think everything is happening everywhere, everything all at once. It can be a blessing and it can be a curse, but I think if you take the main characteristics of the Israeli healthcare system and the needs for startup to also have the country over region reimbursement and support, it can be a perfect place to start with. I think that the main things that I see in Israel that are very relevant for startup is first that it has a very strong public system, healthcare public system. I think the physicians within that system, which are very strong, are very, very tech savvy. They're willing to take calculated risk, not only in using devices and being partners in research, but also affecting procurement. We'll talk about that later, and also creating, taking calculated risks. I think the adoption of innovation is very, very high if I compare it to other countries that we work or I see. And in the last few years, we've also been seeing that there is competition within the health organizations to be attractive to startups. So it's kind of like, I think the equation is changing, and that's part of like the prestige that health organizations are looking for in there. So they're opening their doors widely than they used to be. Generally, I think that the system moves with speed, has a great network, and not to forget that the ethnic diversity in Israel is something that can be considered, and with the data that we'll talk about, can be a major pivot for reimbursement and coverage and go-to-market in other countries as basis. So this is just a general side of the characteristic that we usually show. I think that one of the things that I usually look for and I usually look at is the health expenditure out of the GDP. In Israel, it's been decreasing actually, like in minimal percentage, but still decreasing at 7.5%. For compare it to the OECD average, it's 9.5. So that means that we're a very efficient, if I have to say, highly efficient, over-efficient system. And that creates a lot of burden for the health system administration to cut costs and to be more and more efficient. It can be beneficial for us, but we do have also other ways to create spending and get our products into the market. I think that one more characteristic that I would like to show that impact the way the insurer and the provider thinks is the fact that the population structure in Israel is different than the one that we see in the EU and maybe other countries, but mostly from like compared to the EU, because it has a high birth rate. So we are the same, it relates to the aging population, but the high birth rate creates a situation where there's a high investment, especially with insurance within the primary care and family physician, which creates a great door opener as well for technologies and major budgets that are allocated to that turf. And if I look at the key highlights of the healthcare system in Israel, I think that I usually say two things. First of all, as I said, it's a super centralized healthcare system. It has a national insurance law that we'll touch later. Everybody is covered. It's covered out of 4 HMOs. We have not that many general public government hospitals, 21, and private hospitals that are semi-private. And the annual transition between the HMOs is 1%, meaning that most likely a patient will, from cradle to death, they'll stay in the same one, and that creates a very good advantage for the second pillar, which is having everything that has to do with the digital innovation and big data. You probably know that, the two leading HMOs, Clalit and Maccabi, has full patient records, and they're, developing their capabilities more and more in regards to what we can do with that data. But that leads us forward. And that's part of also that what the government in Israel sees as, the new oil, everything that has to do with data commodities. And we'll touch about that later as well. I think that what, for me, is most important for you to know is a lot of the strategy that I'm talking about relates and builds on the national healthcare law. We'll talk about that very soon. Second thing is, if we look at the provider overview, we'll see that the Israeli healthcare providers, I categorize it into 3 main pillars. First of all, is the HMOs. What is interesting about the HMOs is that it's both payer and service provider. That's not something that is common as far as I understand in the world, meaning that they have the mandate, and they have the power to also provide cares that eventually are preventative medicine, something that's not necessarily acute. That is very much of an interest to us. The second thing is the medical centers. The government, mostly the government ones, and the one I presented earlier are government owned. But I have to say that what for me is most interesting is that most of the private healthcare medical centers in Israel are actually owned by the HMOs in some percent. The government is trying to control that, but that means that in Israel, there's not really private care, like pure private care. And that means for startups that in case you start in private care, you can also move into the public system in more ease because there is a transition. We'll talk about that later. And the last thing is that the Ministry of Health is also serving as a provider. It creates a lot of barriers because it's the regulator. They're not necessarily have to be service providers. And what we see in recent years, and this is going to change, is that most of the services that the MOH is providing will move to the Health Maintenance Organization, the HMOs. We saw that with dental care. We saw that in geriatric care. We saw that with mental health services. So it's moving. I think it's a good thing because eventually there's a lot of criticism. And I think that generally the ministry should be a regulator and not a service provider. So, but they still have the vaccines, the preventive medicine to some sort, rehabilitation, and comprehensive community care. I'm going to touch really, really briefly about the way we fund the Israeli healthcare system is funded. So we all pay premium taxes, direct and indirect, that eventually gets into the social security that collects everything and distributes it to the HMOs. The HMOs get their money out of a capitation model that differs between, that creates a different calculation between each citizen according to its age, gender, and geography. So I can say, instance, for Clalit, which has more of like the demographic elderly population, they get more money than Maccabi, which has a younger population. They still think it's not enough, and they have a lot of there's a lot of debate because it's a lot of money that is moving, but is important, but because it impacts the money, the expenditure that they can take out of every year. And there's also the out-of-pocket payments, which is the semi-private and the private insurance that will cover. I want to say a few things about the national healthcare law, which is important for us because eventually, besides the fact that it says that every resident is entitled for health insurance by a choice of HMO, it also has a basic list of services and pharmaceuticals that it was a screenshot of what Clalit has provided back in 1994, and ever since that basket is evolving. I think one of the main things that we need to consider when we think about the healthcare basket is part of the law. It says that under medical consideration, the providers of the pharmaceutical services and medical technologies needs to be within reasonable quality, within a reasonable time and distance under the HMO's budget. That means that it gives a lot of freedom and gray areas to the HMOs to decide what is reasonable, what is reasonable time and distance. And that also creates part of the, I would say, clashes within the industry and the reasons that patients choose to move between HMOs. And looking into the whole funding, then I think the best way to show is that eventually we have a public health basket. 100% of the population is insured. The total budget is 54 billion shekels. On top of that, we have the annual expansion process of that basket. Most of you probably know from your experience the Israeli health basket process, Sal HaBriut. So Sal HaBriut, the health basket, is just like the additional add-on, a yearly add-on to the basic coverage. Meaning, and we'll touch about that later, that in your go-to-market strategy, when you look at the technology, if it's covered here, then eventually it will, and you'll get it, then it's going to be there forever for the entire population. So that's a major consideration. On top of that, the supplementary insurance of the HMO, we have 79% of the population insured. The total budget is 5 billion shekels a year. It's not a lot, and we'll talk about it's decreasing. And on top of that, we have the private insurance, which is growing year over year. There's a lot of also companies that are now granting private insurances as a way to attract employees. But the interesting thing is that nobody knows what is the spending, okay? Now, what is interesting to know as well is that these two are given by the HMOs, and this is totally private. One of the things that the Ministry of Finance in Israel is trying to do is to create a situation where us as citizens would know what we have, because most of the people in Israel, if you take a look at the numbers, have duplicity of insurances, and that creates a situation where there's spending that the Ministry of Finance is trying to decrease, so we'll spend less. But I think that going forward, for these two pillars, it's mostly relevant for patient-specific technology. So when you think about your technology, you need to think about who is it meant for, and from that to start to aim what is your go-to-market strategy to Israel. Now, I need your attention because I worked very hard for this slide. I think if I eventually, I don't see most of your faces, but when, this is the whole Torah. Eventually, when I look at how a startup should think about its go-to-market process flow, it needs to see first to consideration. And I think this is the most important slide of this presentation. So even if the background was a bit boring and stuff that you knew, what?
I mean, the crux of the matter, that's where the juice is, yeah.
Exactly. So I had to go through the background because eventually, some of the things I said are leaned here, but eventually this is the main thing that you need to know. I think that the two main questions in Israel that you need to consider in regards to technology, first and foremost, is to understand if it's a patient-specific technology, if eventually a patient will wear it, use it, it will be specific to him, or is it an infrastructure? I'll go, the rest of the slide would be, we'll talk about more over here. So I'm gonna go over it, but we're going to go back to this slide again. So I'm just gonna go and say general consideration, and then I'm going to say a few words about each and every one, especially what's happening here. I know it's probably a bit of a busy slide. So first of all, is it patient specific? If it's infrastructure, and in both cases, what I would ask myself is whether it's covered by the National Health Basket. When I say covered by the National Health Basket, is first like the main pillar, like the 100% of the population. Because if not, I would have to go and see how can I get it covered. But in case it's covered, let's say it's a patient-specific technology, it's covered by the National Health Basket. That means that the citizens are already getting it, and we need to go into a market that is already being covered. We have to think first, who is the payer? So that's the third question you need to ask yourself. I guess you ask that in every country, but in Israel, there are two main players in regards to the payer. Is it the HMO or is it the hospital? Eventually, you get the procurement division, and procurement, I have to say, in Israel has becoming increasingly, I would say, considered. It's become, their power is increasingly and becoming more and more substantial within decisions in the HMOs in the hospital. So eventually you have to have the physician support in order to convince the procurement. They're gaining a lot of power because of the monetary constraints. Used to be the other way around in Israel. If you talk 10, 20 years ago, the physicians are also talking about it, that their power is decreasing. So a lot of the work would be around the procurement, and around the procurement, we'll talk about new business models, but eventually you have to go and compete with existing technologies. If it's not covered by the National Health Basket, that means you need to see whether you're eligible for a National Health Basket submission. When we spoke, when Gilad and I spoke before the presentation, I think this is one of the main things that most people are not really into specifications in regards to what is eligible and what it's not. And the reason I marked this in red is because we all know the annual process, and we see it in the, in the newspapers. It's a big thing in Israel, especially when you come to the end of the discussion. But what most people don't know, that for medical technologies, the actual, like the pivot part within the yearly expansion is an actual legal form, closed legal form by the Ministry of Health that decides whether it's even eligible to be submitted and to be discussed within the national process. I want to show you just a second. I want to talk about a bit about the national health basket expansion process. So just a little thing, if you look at this picture, you would see me here at the end. This is I think it's 2010. Back there, back in the days, we're in the old building of Tel HaShomer. But I think so. I've been there for many hours. I think that what is important to know, and I think this is like the sad part, that the average budget allocated for medical technologies in Israel is 5% yearly, and this is in a good year. So 95% is not for medical devices, and that's created a barrier because eventually we compete with usually pharmaceuticals, corporates, especially for startups that might not have the tools as the big corporations, but eventually I guess that if you have a good technology and a good support, you would be able to carry it on. There are 20 committee members and approximately 700 technologies and pharmaceuticals that are being submitted each year. I'm going to go back to the previous slide because I think I lost it. Just a second. Okay, so going back to the eligibility of medical technologies, I think this is part of the things that most people are not really aware of. So under the national procedure with who can be, how do you submit and what do you do? There are a few major considerations that are written here in Hebrew. You have the link down if you want afterwards to see the whole document. But eventually they say out loud that technologies that don't have enough of sufficient evidence can be just a second, can be submitted. It's mostly based on technologies that are for a specific patient, as I say. And I think that the most important thing is that there is a very great gray area that is related to what they say is a technology crawling. So if you have a major breakthrough in technology, the ministry might not think this is a breakthrough technology, and that creates a legal barrier. So most of the things here are eventually are gray areas. So we need to think very carefully if the technology can be eligible for the health basket. And I think that what most people don't know is that it's a very timely and structured process. They have timelines that you need to submit. You have timelines that you need to provide certain documents. There are timelines for certain committees. And if you don't follow that process, you can lose year after year because not knowing the full process. And you have to eventually prepare for 2 or 4 years ahead, because eventually, as I said, the competition is so big that you have to be very precise with your evidence. And I think that what is good thing is that eventually for medical technologies, the real world evidence and local evidence is becoming increasingly important, is a game changer, but you always will need the evidence and the professional support. The HMOs are a very, very pivotal player. This committee, as I told you, is 20 people, but the only people that go year after year and know the whole tricks and shticks are the HMOs, and therefore their support and the professional support is super important. Okay, so any questions? I feel I'm talking to myself. So any questions up till now?
Yeah, it's a good time to make a little question stop here. So anybody? By the way, I didn't say it, but if people have questions throughout the presentation, you're welcome to use the chat function. Hannah is monitoring the chat function and can read, stop Shira and read any questions you have if you're not comfortable just asking directly. Shira, I'll ask one maybe question for a 1 minute answer question. Can you give an example? Medtronic has a lot of experience in introducing new products to the Israeli market. Everything from
Yes.
insulin pumps that I think Medtronic were the first to introduce to the market, through some of the valve, type products. So give us an example of a particular product, of what was the process and how can we learn from it? What to focus on?
I'll give you a great example.
Real world
I think that and something that is very close to my heart. Medtronic, I don't know if you know, introduced a few years ago worldwide a technology that's called Micra. That was a game changer in the overall heart pacing device. We moved from traditional pacemaking of opening and putting it like a huge pacemaker into a capsule that is transmitted into the femoral, into the aorta, minimally invasive. It changed the way the physician worked. It changed the whole way of patient treatment indication, and we considered it as a technological breakthrough. Now, I've been back when it was when we started. I was then the market access director for the Medtronic Israel team, and I insisted that this is a breakthrough. We were stopped for 3 years in this committee. So this technology, and still is, did not go into even the discussions, because the ministry and the forum within the ministry and the legal way thought it's not, in the National Health Basket from the 1995, it says heart pacemaker, it's pacemaking, it's the same thing. So we're not getting into that. And we said, no, this is a major breakthrough. Also, I have to say that it costs 10 times more. So you can't expect the system, like the HMOs, to fund it. We saw that some of the hospitals are granting it according to specific innovation budget that they have, according to business that we did, but they didn't grant reimbursement on a national level. And interestingly enough, we only wanted it and still want it for specific patients that cannot receive the traditional pacemaker. So what has happened after 4 years of having a professional support by the union, and also appealing to the Ministry of Health, we were able to have now what we call Mifchanet Chimicha. It's kind of like a pilot project for a reimbursement that is for 2 years only, in order to see what is the patient numbers, because the budget is huge on a national level. So the ministry said, okay, we would, after 4 years, we would accept that, we understand this is a breakthrough. We understand there's a legal issue. We need to find a way to be more precise and sure about the patient numbers. And therefore, we created this sideway. This is not something that usually happens. I think it came from our persistence that we insisted that this is a breakthrough. I can tell you the same thing about the hybrid closed loop system in Medtronic. I think part of the discussion that we had in the ministry is still here. whether it's a breakthrough or not, who is granting it. There are some technologies that are eventually an infrastructure technologies, but is granted to the same patients. And some of our discussions with the ministry is it an infrastructure or is it patient specific? So the gray area here gives a lot of power to the ministry. It's a closed committee. You can get a reply, but you don't know the consideration. I think this is something that we're under METIC are trying to change as well. But that means that even if you get a no answer, I don't think that's the final line. I think you should, if you think it should be there. And also advice. I think one of the good things that within the ministry is that there's an open door, especially within the medical devices administration. You can advise. So if you have any thoughts, don't, just set a meeting and see what they think, because a lot of the times when we want to submit something, I go a year ahead and ask, what is the evidence that you need in order for this technology to be reimbursed? And then I get an answer. I have to see it in 50 patients, in 4 hospitals, under this and this and this indication. You get the support of da-da-da-da-da. But you don't waste time in thinking it should be. You need to be more active in asking around and also very much getting the physician support. Any questions about that?
No, thank you, Shira.
Okay, so moving forward, I don't know how much are we with the timelines, but in case I'm just going to move forward to these two. So I touched and I tried to touch. I hope it was you understand what I meant. So what I touched up till now is the consideration that you need to think about when you think whether it's it can be submitted or can be part of the national the public health basket. Now, when I look at you know what, I'll go back to this slide just a second. Okay, so what I touched now in regards to what I just said is all this track. Okay, what can be done in order for you to see if you're eligible for submission? In any way, I think that in case you're not eligible out of clinical or out of market use, you have to go here. You have to think in parallel. So in order to get eventually more clinical evidence and more market use, you can, eventually have the national health basket. You can also go to the supplementary health insurances. You can go to the private insurance companies. You can go to the private medical centers. But I think very interesting, and I think this is something that most startups not necessarily think of, is that you have innovation budget within the HMOs and the hospital. As I said, everybody are very keen to have, the touch of the industry. They want to be part of, the startup nation. They want to have prestige. And what we see is a lot of the time you can get into the HMOs and the hospital under specific innovation budget that sometimes come from a specific KOL. So in different hospitals, in case you have a medical staff and you have a demand from the field, you will see special budget that will be granted over here. Sometimes when physicians are granted with innovation budget, eventually they work in the private system as well. So they will demand it in the private system. The private system will affect eventually the use under also research and clinical, but under the supplementary and the national. So sometimes you can also, this is not something that has, a specific process. This is very case by case. But I think these days, the innovation budgets are becoming increasingly more popular because it also creates a situation where the institute are not obligated, they're not bound to something that is forever. So it's easier for them to grant it in order to keep their physicians happy as well. There's a lot of competition between the big hospitals and especially talents. So I think that's a major thing we need to look at. And I think that one more thing that can be very helpful is to understand that innovation, and this is things that I do and work with, is not only within the medical technology itself. I think that there's a lot of acceptance and openness for different type of agreements that create a win-win situation between the organization and the physician and the company, and of course the patients. I use that quite often. I have to say that it's not easy at all. It has a lot to do with trust, but eventually under the health basket and generally with some of the health organizations, including hospitals, we do have risk sharing agreements, meaning that is agreements that you have some sort of a budget, could be like an innovation budget that you say from that point onwards, we pay for the procedure. So you give the health organization the ability to adopt innovation, to adopt the technology, but not taking a risk of a monetary risk. You kind of allocate their budget. The second thing is outcome-based performance agreement. This is a bit more difficult. I can say, for instance, for example, Medtronic has antibacterial envelope called Tyrex. You put it on it's kind of like a small pocket. You put it within every time you can put it in order to prevent post-procedure infections. It dissolves after 3 months, and it's created a situation, especially in high-risk population, that don't need to reopen them and they get infected. In England, for instance, Medtronic created an outcome-based performance agreement with the NHS, meaning that in case a patient is infected, Medtronic subsidize or does something that cover the cost of the procedure. So that takes the burden out of the organization. Last but not least is everything that has to do with real-world evidence and data collection. I can give you a really nice example, something that I was involved in, very proud of. Medtronic in Israel launched the GI Genius. It's an add-on AI, let's say eye for colonoscopies in order to raise the ADR, the adenoma rate for colonoscopies. Eventually, this is something that is, it's in the health basket. Nobody needs that add-on. Why should I pay for something for an extra eye? But eventually, the clinical studies show that it's 25% more detection rate. But what's happening in the real world? We created a situation with Shira Medical Center where we did a combination of real-world evidence data collection and a worldwide study where Shira actually bought all they equipped all their rooms with this device and created a situation where we tested the real world evidence in compared to the clinical. This created a lot of prestige for Shira as well, and we got our device in Shira to be the first public hospital within the world to have all its rooms equipped with the GI Genius. So it was a win-win, and I can say that now patients want to go there because of this system, and it's getting increasingly accepted. So on that aspect, and I think on the business model, what I can say is that sometimes I think the way you need to plan your go-to-market is the fact that you need to give devices or technologies out, for no cost, or plan for some budget that would not be a marketing budget, but would cover the cost of the technology in order to give the health organizations the ability to use the product. Sometimes we have a tendency, and I see it within our company as well, not to give anything for free. But I think that sometimes if you build it correctly, you can, by granting X number of technologies or the ability to act within it, then you're able to get a lot more, especially if you're creating studies that will afterwards use in reimbursement settings when you file for reimbursement in Israel or nationwide or worldwide. Questions so far? No.
Good, Shira, we're getting to the end of the session from a time perspective. If you have in 30 more seconds, and then we'll conclude just to respect everybody's time, okay?
Yeah, so just saying that there are special programs to just, put a few names on. There are government initiatives. there are HMOs initiatives, and there are medical centers initiatives. Everybody wants to be, so I think there's, within those initiatives, there's a lot of way that the go-to-market could get specific innovation budget, and from that point onwards, to build bottom-up your strategy in order to get to national coverage. And again, saying that I think physicians and the acceptance of, you know, the actual use, especially in Israel, is super important. And the ability to have a win-win situation with research access and you know, eventually patients that would enjoy the technology. That's like one of the, you know, that creates the perfect storm. And that's it from my behalf.
Shira, thank you very much. That was amazing window into the very non-simple Israeli healthcare market. Obviously, I guess a lot of people would have more questions, but then I encourage them to contact you, you know, offline, and see if you can engage with them in whatever different capacities you do to help. But that was fascinating. Thank you so much. Your experience is really valuable to MCI and to the people who participate, and those that will view that presentation and webinar later on. And we're grateful and thankful for you for taking the time and sharing it with us.
Thank you, everybody.
Thank you.
Bye-bye.
Bye-bye.